Hello, everyone. This is Dr. Elliott. Just checking in. I have been grading papers all afternoon, and it's slow and arduous, I have to say, because this is not the most ideal way to teach clinical assessment. I'm just going to be honest. I'm used to teaching this class on ground, and some of you are really just getting it, and I still am seeing a lot of struggles with the case conceptualization. Um, I'm still finishing the second half of the week 4 PowerPoints, and then I was going to move on to the week 5s. And so I just wanted to pop in here and see if I could maybe help clear up some of the confusion about what actually goes into the case conceptualization. So for one thing, I just want to say when you're doing biopsychosocial assessments, the case conceptualization, like out in the real world, is not something that you're probably actually going to have to put in there. This is something that's pretty unique to graduate school. And it's a way for you to demonstrate to your professors that you have done the research and that you have thought out about the diagnosis and the client. And from your theoretical perspective, you've come up with some ideas about why you think the client is suffering the way that they are and how you're going to use the theoretical interventions to help move the client forward. So I'm still seeing quite a few of you who don't have any theory in there at all. I saw a couple of referrals to AA and things like that. And it's like, no, we're not substance abuse counselors, even though, we might be treating co-occurring disorders. But even in that same situation, if you were going to refer somebody to AA, why? What's the conceptualization of that? It would be, oh, well, the client has maladaptive, like from a CBT perspective, the client has maladaptive coping mechanisms and that are built around their lack of self-esteem and self-confidence based on blah blah blah, right? And because we're going to help work from a CBT perspective, we're going to help with thought stopping techniques, and we're going to help challenge some of those negative cognitions, negative belief systems, and help the client develop some self-esteem and self-confidence, which we would expect to help improve, and change their behavior. So that's an example of a CBT based, really basic conceptualization. I think I gave some of you some really specific feedback that kind of gave some examples of different types. And I feel like I'm spending a lot of time giving individual feedback, and that's why it's taking me so long to grade. And so I thought maybe if I hopped in here and made a video, maybe all of you could benefit from one explanation. So what goes into, and I want to say something positive too, though. Most of you have done a really great job. You're doing great with the diagnostics piece. I would say the one overarching thing that I keep seeing is that folks need to do a little bit more differential diagnosis. And I think that comes with time. So I think there's another clinical assessment, like a more advanced clinical assessment class after this one, where you do a little bit more of the differential diagnosis. But I do want to just kind of bring that to your attention that when you have a whole bunch of disorders that you're diagnosing, it's pretty unlikely. I would say less than 10% of the population has more than 2 diagnoses, and some of our most severe clients maybe have 3. But if you notice that you have 2 or 3 diagnoses happening, you probably need to go back and read in the DSM and see which one is going to trump the other, because most of the time you're diagnosing things that shouldn't be diagnosed together, because one is going to trump the other. I think I made a video on depressive disorders and how persistent depressive and anyway, I don't need to go back into that. Let's see what else. So what actually needs to go into the case conceptualization section? A lot of you are just repeating the summary of the diagnosis, and that's not what goes into the case conceptualization. A little, maybe 2-sentence quick summary is fine. But what I want to see in the case conceptualization is I want to see how you're thinking, not just diagnostically, but from your theory. So if you're not solid in your theory, that might be what's showing up here in your papers. So also there's a couple of you who picked like humanistic or person-centered, and those are kind of atheoretical, so it's going to be harder to do those because there aren't specific interventions that go with them. So when we're researching theory, there's a few things I want you to keep in mind. So theory, this is what you need to know about your theory, your whatever your chosen theory is. You need to know who the theorists are, not that you have to put that in your case conceptualization, but knowing who they are, knowing what the basic uh, philosophical assumptions of the theory are, and the role that you are going to play with the client, like how you show up in that theoretical relationship and that therapeutic relationship. And sorry, I'm still getting over being sick. My brain is a little slow. Oh, and then every theory has kind of a generic set of goals and a generic set of interventions. And we don't want to just throw those generic goals and interventions at every single client that we have. But I'll give you an example. So let's say I'm choosing psychodynamic theory. And psychodynamic theory, I know, is a postmodern theory. And postmodern theories, basically, we can break theories up into modernist and postmodern theories. And modernist theories, they believe that there is one truth to be known. Postmodern theories believe that there are multiple truths to be known, and multiple truths are based within a social or cultural context, right? So there's the modernist theories is everything behavioral, everything medical model is there is an answer. Science says A plus B equals C. And over here in the postmodern theories, there is, truth is contextual. Truth is, it's in the eye of the beholder, based in the context of the situation. So from a psychodynamic perspective, then we might say that somebody is suffering from unconscious material that is like if they have behaviors that are maladaptive, we would say that those behaviors are due to unconscious material. Therefore, the generic goal of psychodynamic theory is to help bring the unconscious conscious. And the theory is that once the unconscious is conscious, then the client can figure out from there what they want to do with it, and we would eventually see behavior change. And there are a lot of different ways to help erupt material from the unconscious. And we could do that through play therapy. We could do that through art therapy. We could do that through dream analysis. We could do it through free association. We could do it through just the therapeutic relationship itself, through transference and countertransference, things like that. So there's lots of different ways that we can bring that unconscious material to the surface to be healed. And the other part of that theory says that the psyche has the ability to heal itself. Just like our body has certain healing abilities, you get a cut on your finger and you don't have to tell your brain to send white blood cells to your finger. It just automatically knows what to do. Well, our psyche has the ability to do that as well, except when it comes to trauma. And so trauma would be kind of like thinking like when you break your leg, you have to go to the doctor and get the bone reset, but your body does heal itself. But if you don't get the bone reset, it's going to heal pretty funky, right? If it heals at all. And our psyche is very similar. It's like that's where we come in as therapists. We help kind of reset the bone structure of the emotions and from a trauma perspective. But then the rest of it, the container is what helps heal. And that container is made up from a psychodynamic perspective. That container is made up of non-judgment. It's made up of the client and the therapist creating a therapeutic rapport and a therapeutic relationship that is unshakable and creates this beautiful safe space for people to look at all of that deep, dark, quote unquote, ugly, unconscious material and bring it to the surface. And how we heal it is just simply by loving it and loving ourselves anyway. And so that is the work in psychodynamic therapy. So when you have somebody, suffering from anxiety or depression or things like that, it's helping them to uncover this unconscious material and learning to love all the parts that come up and show themselves to be healed, working through all of the shadow material. So that's kind of a long-winded psychodynamic approach. I know a lot of you are using CBT, which is lovely because it's easy. And it's very basic, you know, from a CBT perspective. Then behaviors are caused by maladaptive thinking. They're caused by negative thinking habits and negative self-talk and the way they view themselves. And so the biggest part of that goal is to help interrupt some of those habitual thinking patterns and get in there. And even from a trauma-informed CBT perspective, you can go a little deeper with like the emotional capacity and things like that. But some of the typical intervention strategies of CBT would be like role play and journaling and thought stopping techniques and thought logs and things like that. Homework, you're going to do a lot of psychoeducation, you're going to do a lot of homework with the client, and those would be strategies that I would expect to see. But before you give me the interventions in the case conceptualization, I need to understand why you think CBT is going to work for this client. So from a CBT perspective, the reason these interventions are going to work is because the client is suffering from, you know, negative self-talk. They're suffering from, their relationships are suffering from this can't even talk. This perseverating on negatives, right? So anyway, I hope that clears it up a little bit. And what I'm going to ask you guys to do from now on is if I give you a grade that is less than satisfactory, it is certainly not because I'm picking on anybody. It's just really, really important that we learn this piece before you finish this class. And what I'm going to offer is, if you'd like to bring up your grade, just send me a 1 or 2 paragraph case conceptualization, upload it with the other assignment, and I will use that to replace your grade, because that's really, at this point, that's really all I'm looking at. I want to know that you got the diagnosis in the ballpark. I want to know that you supported the diagnosis. I want to know how you're thinking from your theory about the diagnosis with this client, and how you're going to help the client move forward with theoretically specific interventions. Okay. So if you can get all that into a little 2-paragraph dealy bobber, that would be wonderful. That's a technical term there. Yeah, don't stress too much over this. I know you guys are going to get this. And I'm just going to keep at it with you until you do. 101, if you want to shoot me a quick text and ask questions, that's totally fine. Okay, I hope you have a great rest of your day. Talk to you soon. Bye.